Our adrenal hormones include the hormones produced in the medulla, which is the inner portion of our adrenal gland, secreting catecholamines, and it works directly with the sympathetic nervous system to do so. And the catecholamines secreted include epinephrine, the primary catecholamine, secreted from the adrenal medulla, and norepinephrine. These come from dopamine and they are synthesized in chromaffin cells, which are neurons from the sympathetic nervous system that have been modified. And they're regulated by the sympathetic nervous system, not the HPA axis, which is going to be different than our adrenal cortex hormones. The mechanism of release is preganglionic nerve fibers will synapse with these chromaffin cells. They will release acetylcholine as their neurotransmitter, which binds to nicotinic type 2 receptors on the chromaffin cell. The chromaffin cell will then directly release the catecholamines, norepinephrine and epinephrine, directly into the blood like a hormone. And then those hormones, those catecholamine hormones, can stimulate both alpha and beta adrenergic receptors systemically. So they can really increase that sympathetic nervous system response. The benefit of being able to secrete catecholamines like this is that they last longer than neurotransmitters, so your fight and flight response can last a little bit longer. They increase blood pressure and heart rate, circulation to skeletal muscles, respirations and bronchodilation, and they're going to also stimulate blood glucose. They're going to encourage glycogenolysis or breakdown of glycogen and gluconeogenesis, the dumping of glucose into the circulation. An epinephrine can even inhibit insulin release, further encouraging glucose to stay in the blood. This also will decrease digestion. Now, the outer portion of the adrenal gland is the cortex, and then these hormones are all synthesized from cortisol, not like different than our catecholamines that came from dopamine. We have three layers, our G, which is the zona glomerulosa, the F, the zona fasciculata, and the R, the zona reticularis. And we have to remember that the G secretes our salt, really regulating hormones, mineral corticoids. Our F is going to secrete our sugar, our glucocorticoids, our sugar regulating hormones or stress hormones. And our zona reticularis, our R, is going to be secreting our sex hormones or androgens. The HPA axis then can be seen here where stresses or different biological rhythms can stimulate the hypothalamus to secrete CRH acting on the anterior pituitary, to secrete ACTH acting on the adrenal cortex, to secrete cortisol, for instance. Then that's going to have a negative feedback effect on both the hypothalamus and the pituitary itself. So the HPA axis, we start with our paraventricular nucleus of the hypothalamus secreting our CRH, which then, if we had ACTH present, that would inhibit CRH release, a negative feedback loop. CRH will stimulate the anterior pituitary to release ACTH, and ACTH stimulates the adrenal cortex to release all cortical hormones. Cortisol inhibits both CRH and ACTH of note. There are other stimuli, including stressors and certain biological rhythms that can stimulate these hormonal releases. First, looking at our mineralocorticoids, the first hormone region of the adrenal gland or the adrenal cortex. The main hormone at play here is aldosterone, secreted from the zona glomerulosa, and it's synthesized by aldosterone synthase. This is partially under the control of ACTH, but it's really under the control of the ROS, the renin-angiotensin aldosterone system, as well as serum potassium levels. And we'll see that aldosterone will encourage increased blood pressure by increasing water reabsorption from the kidneys, increased serum sodium by decreasing urinary excretion, decreased serum potassium by encouraging urinary excretion, and increased serum pH by increasing urinary excretion of hydrogen. The ROS, if we haven't recalled, involves angiotensinogen secreted by liver cells, hepatocytes, and renin secreted by juxtaglomerular cells of the kidneys, which then will convert angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by our angiotensin converting enzyme or ACE, which is secreted by the pulmonary vascular endothelium. And then angiotensin 2 is active. It's what's going to stimulate the zona glomerulosa to release aldosterone. It also can directly induce systemic vasoconstriction, and it can stimulate sodium and water reabsorption. So aldosterone, our hormone coming from our adrenal cortex, stimulates the production of proteins within principal cells in the distal renal tubules. So our sodium potassium pumps on the basolateral side, the side that's not by the lumen, creating a gradient. The epithelial sodium channels on the luminal side, encouraging sodium reabsorption, and renal outer medullary potassium channels on the luminal side, encouraging potassium excretion into the urine. Ultimately, we get increased sodium going back into the blood. Water then follows, which increases water reabsorption and then corrects blood pressure. And it creates a negative electrical gradient across the lumen, which promotes the secretion of potassium and hydrogen into the urine. Things that trigger the ROS or increased aldosterone by definition is decreased renal perfusion, which could be due to low blood pressure or low blood volume, increased serum potassium, decreased sodium delivery to the kidney, or increased sympathetic signaling. Our next adrenal hormones, our category is glucocorticoids, which really includes cortisol and corticosterone. These are secreted from the zona fasciculata and regulated by the HPA axis. And they respond, the effects, it responds to immediate stressors, but it's going to increase energy availability. So fats and proteins get broken down, gluconeogenesis starts, appetite stimulated. It's going to also increase red blood cells, and it's going to increase serum calcium from bone resorption, which over time could lead to a complication of decreased bone mineral density. And there can be anti-inflammatory effects like decreasing blood vessel permeability, which over time could lead to immune suppression. Lastly, our category is our androgens. This includes DHEA and androstenedione. It's secreted from the zona reticularis, and our adrenal androgens can be converted to testosterone and estrogens in the peripheral tissue. It is the main source of estrogen in our postmenopausal AFAB individuals, and it affects our secondary sex characteristics, and it can stimulate axillary, pubic, and facial hair.